All right. Put my bubbler down. All right, thank you guys for coming. We'll go ahead and get started. So we'll go to the agenda. We have a lot to get through. So we have a speaker, Bridget, who's here to talk about DBT, talk about Net Promoter Score, average daily census, a staffing update, social determinants of health, fire drill response, the Packers VIP workflow, meet our chaplain, CPI, we'll do a review of one of our CPI moves, press gaming, infection prevention, charge nurse update, Civilitas, code button update, infection prevention, it's on there twice, sorry about that, staff pickup, and then at the end we will end with one of our health coaches who is here to talk. So with that being said, we're going to start out with Bridget to talk about DBT.
All right, thanks for having me. So my name is Bridget Blaine. I'm one of the DBT therapists at Bellin. I'm not away. Okay, good. So I've been over at Bellin Riverside for 6.5 years, but I've been doing DBT for the last 10. I was intensively trained in 2013, and at that time was working for American Foundation of Counseling and part of the DBT team there. We moved our program to Bellin Riverside in January of 2017. So I've been doing this for a long time. The average shelf life of a DBT therapist is 3 to 5 years, so I'm far exceeding that. So I just kind of gathered some of the stuff that I've shared with other people about what DBT is, and I'm happy to go through that, but also happy to answer questions if people have them about the program. So if you have questions that you want to make sure that I answer, please let me know at any time. In the materials that I sent over, I did send over our frequently asked questions page, some program information just about like what DBT is. We do send both of those to people when they get added to our wait list. So if you've ever added anyone to the wait list, just know they're gonna get that in the mail, along with a welcome letter saying like, hey, you've been added to the DBT wait list. Please read this information and make sure you do for sure wanna do this. And if you do, please sign and send this back. Because we are getting probably 50-ish referrals per month. We've decided that at this point, we're only gonna call people that are returning that paperwork until we catch up with that. And then if we end up catching up, which we never will, then we will call people that haven't returned that paperwork. So if you have a patient who's saying I've been added to the list, a really important thing for them just to be checking is, have you turned in your paperwork? Not just am I on this list, because any referral will go on the list, but only patients returning that welcome letter with a signature are gonna get a call. So that's just one really important thing that I'm trying to make sure everybody knows, because that part has changed. Like so far this year, we've added almost 400 people to the wait list, and we have 2 DBT therapists. So, I mean, as you can guess, like there's just no way for us to stay caught up with that. And one of our therapists, so Danielle, she's on maternity leave. It has been a long, long 9 weeks. Her last week is next week, so she'll be back starting the week of the 26th. And then as well, like a huge portion of people are gonna come off of our wait list because we're gonna be rebuilding her caseload. She's gonna take her patients back that I've been seeing, so we're gonna have a lot of openings. So if people are unsure as to where they are, now's a really good time to check. Anybody have questions about that before we just kind of talk about what is DBT? Okay. Also to clarify, we do have adult, teenager, and DBT for kids in our program. We have a huge program despite only having 2 providers. So we have 3 adult groups that run, 1 teenage group, and then DBT for kids. So ages 5 to 12, and all of that work is done in individual therapy with the parents, because like a 5-year-old up to 12 wouldn't be a very good mix for a group. So there's 4 groups that run, and then the DBT for kids is done individually. Okay, so the history of DBT. So DBT was developed back in the 70s by Marsha Linehan, specifically for people that were meeting the diagnostic criteria for BPD. So basically we're looking for patients that either have that diagnosis or areas of struggle in the following criteria. So problematic emotions, so that emotional sensitivity, that reactivity, those emotions that, you know, are like riding an emotional roller coaster that people just cannot seem to get off. Those emotions that happen so easily, so quickly, so strongly, and then take a much longer time to return to baseline than what that might be for another person. Interpersonal dysregulation, so with another person, so those relationships that are intense, they're chaotic, they're like, I love you, I hate you, you're my best friend, I hope you choke and die. You know, that back and forth, push and pull, or also relationships like the person just can't seem to make them, can't seem to keep them, or on the flip side, will do things that they might not even value or agree with to keep people around because they're fearing this abandonment. Self-dysregulation, so problems like with their self-concept. Sometimes I talk about people that come into our program kind of like a chameleon, like they might take on the qualities or attributes or characteristics of a person when they're spending time with that person, or with that group when they're spending time with that group, and not really have like a stable sense of self, kind of just changing that based on the environment and what might fit. Or also like a really critical, negative, problematic self-concept. Behavioral dysregulation, so this is where we're seeing a lot of harming behaviors, suicidal behaviors. We have a ton of referrals for people with eating disordered behaviors, substance abuse behaviors, risky sexual behaviors, reckless driving, shopping, eating disorders, stuff, I think I said that one. But all of those behavioral problems, and then cognitive, so that rigid, all or nothing, black and white thinking. Like it's either a good day or a terrible day. Like today's either gonna be great or absolutely terrible. I'm good, I'm bad, you're good, you're bad. So those are the 5 areas of dysregulation that we're looking for when someone gets referred to DBT. Our program has a wider net of inclusion, so we have various levels of severity from like pretty mild up to pretty severe. So even if someone is not meeting all of those criteria, they still can be an appropriate referral. So someone asked the question about what is DBT. So DBT is a form of cognitive behavioral therapy. So if you're thinking about like the different types of therapy, DBT falls under CBT, but is much more behaviorally based than a traditional CBT approach. So in CBT, there's a lot of focus on cognitions. DBT looks at changing thoughts, emotions, and behaviors, but has a really high behavioral component. So the D of DBT means dialectical. So Marcia, when she was developing her therapy, said like, hey, like we don't want to be too change focused because that doesn't feel very good. But at the same time, we don't want to be too focused on validation because we might not get enough change. So the dialectical component is balancing, right? Like saying two even opposite truths can be true at the same time. Like I can be excited and terrified about getting on this roller coaster. So even opposing forces can both have truth. And in DBT, we are really working to get unstuck from those extremes, unstuck from those polarities, and try to balance those validation and change strategies. So I'm going to talk to you a little bit on some future slides about what kinds of skills we teach, but you will notice that there's going to be a balance. So we are not just having people, let's say, just tolerate, 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 accept, accept, accept. We're going to also balance those with some change strategies too. The B is the behavioral part, so dialectical behavioral therapy, okay? So we are looking at changing behaviors, we are looking at changing responses, we are looking at doing things very differently, like I said, with emotions, behaviors, and also with thinking. So DBT said, okay, we want to add some things to a standard like behavioral therapy, so that's where I reference like that acceptance, not just the change focus. So sometimes people will have been in therapy and they're like, I feel like I'm being pushed, I'm being pushed, I'm being pushed, or I don't feel like I'm being pushed enough. And in DBT, we're really trying to balance that, and that's where Marcia really added that skills component on mindfulness. So in DBT, there's a ton of focus on mindfulness, so accepting, tolerating, being in the present moment, and balancing that with change. So not only are we going to learn strategies for changing emotions or for changing behaviors, we're also going to work on acceptance, validation, and experiencing ourselves in this present moment, and really try to balance those. And we're going to focus on this in session. So in session, there's a lot of emotional exposure. There's a lot of trying to sit with, being mindful. We start each and every group with a mindfulness practice, and our participants are learning mindfulness over and over. So it gets repeated in between all of our longer modules. We also added a DBT team. So Danielle and I are the DBT team at Bellin. When she's not on maternity leave, her and I are meeting regularly every other week for consultation. And then we also meet on our off every other week with a larger consultation team that meets virtually across the US. We are targeting by severity and threat. So there's a hierarchy in DBT. So in individual therapy, we are first targeting any unsafe behaviors. So any life-threatening behaviors are our primary treatment target at any time. We do get a lot of referrals for people that are currently and actively struggling with harming or suicidal behaviors, and that's our primary treatment target. Then second would be anything that's interfering with therapy. So if someone is missing appointments, if they're showing up late, if they're not coming to group, if they're leaving early, if they don't have their homework done, if they're not doing their diary card, and then third is quality of life. We also use a DBT suicide protocol, and the LRAMP just got added a couple months ago into Epic. So if you were looking to see more information on that, you can go under assessments in Epic and it will lay out the entire LRAMP, which is Marsha's suicide protocol framework. Working on genuine therapist self-disclosure and really focusing on some emotion regulation and tolerance strategies. So like I said, in individual therapy, that is the primary place where the work is done in DBT. So patients are attending either one time per week or every other week for individual therapy, 45 to 60 minutes per week. We do offer that virtually or in person. Danielle works in the office Monday through Thursday. I work in the office Monday, Wednesday, and work from home Tuesday, Thursday, because we have a really large portion of patients that want to do virtual. So that can be done virtual or in person, but we are really working on enhancing a couple things. So enhancing somebody's motivation to change. I would say we get a lot of people that are referred to DBT that are not very excited about DBT. They're like, people have told me I have to do this. I don't necessarily really want to do this. So we're working on a lot of commitment strategies. Some people really feel like I've tried so many other therapies, which is true, before coming to DBT and they haven't worked, so why would this? So we're really working a lot on enhancing motivation, getting commitment, getting follow through, and we're working on structuring the environment. So if someone has a psychiatrist or has case manager or has other people in their life, we're trying to help them get skilled up to communicate for themselves. So you'll notice in DBT that often we're not talking for our patients, we're instead supporting them and helping them and coaching them behind the scenes to do that. And then there's the group component. So in group, it's a minimum of 6 months. So people would commit to 6 months of DBT skills training. That's how long it takes to learn the entire skills curriculum, and we do teach all 4 modules in our program. So we teach mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. The materials that we teach in the adult group are straight from the 2015 adult manual, and same for the teenage group. Those, however, are from the adolescent manual. Some programs will teach adult handouts to both groups, but we've opted to use the adolescent manual for our teens. Same sets of skills, just geared a little bit more towards teens. Like I mentioned, we have 3 adult groups. So we have 2 on Tuesdays, we have a morning group, an afternoon group, and then a Thursday afternoon group. Currently, our groups are only operating virtually, and we have up to 10 participants per group. So at any given moment in time, we have 30 adults actively in DBT, and our teenage group has the same number. So we have 10 in our teenage group, and that one runs on Wednesday afternoons from 3:30 to 5. The adult groups all run on the same schedule, so each week, all of our groups are learning the same material. And the adolescent group runs on its own schedule, but still covers all of those modules. So in the program, we're learning mindfulness regularly. So about every 6 to 8 weeks, we're covering mindfulness, and that occurs during an orientation period. And that's when we would bring in new members if we have an open group. Or if we have openings in the group, we would bring new members in during orientation. Then we would move into a longer module. So next week, this week our adolescents are starting emotion regulation. Next week our adults are starting interpersonal. So the mindfulness skills are really focused on people being present in the moment. So it's not just meditating. That's probably the #1 thing. People come into DBT and they're like, I hate meditation. Don't make me do that. It's absolutely terrible. I don't want to do that. So meditating absolutely is a way to be mindful, but we're talking about living life intentionally in the present moment with whatever they're doing to reduce reactivity and increase awareness. Distress tolerance skills have 2 main goals. 1, tolerate stress without making situations worse. And 2, to accept reality, even unpleasant reality as it is. Emotion regulation has a ton of goals in it, but primarily we're helping people just know what they're feeling and why we need emotions so we can increase the experiencing and tolerating emotions, but also several weeks of strategies for changing and regulating emotions and increasing pleasant emotions. And then interpersonal, that is a pretty long module. It's actually our longest, and it's for communicating effectively. So communicating assertively for what I want and need, keeping healthy people liking me based on how I talk to them, keeping myself liking me and maintaining self-respect based on how I talk to other people, changing behaviors, being dialectical, learning and practicing validation. So it takes 6 months to learn all of that, so it absolutely is a commitment. People will say like, well, I just like want to get through this as fast as I can. And it is, 2 to 3 hours a week, depending on the frequency of individual, for 6 to up to 12. So our teens and our adults can stay for up to 2 total rounds of group. And I would say that we have a mix of probably like 50-50, people who choose just the 1 round or people who choose the full year. Phone coaching is also a component of DBT. This is very different than most, if any, other therapy. So phone coaching is how patients can get a hold of their individual therapist in between sessions for help with a couple things. One, if they need help with skills. So you got taught a skill in group, or you've been learning this skill and you're trying to practice it, it's not working. Like you're trying to dear man your mom to see if you can go to this concert, and now you're yelling and you're screaming and it just has moved into not being skillful, and you need help getting coached up into using that skill in the moment, or for a crisis situation. So for example, if patients are having urges to be unsafe, if they're having urges to engage in suicide, we actually are asking them to use phone coaching rather than first going to like a crisis intervention, because we want that person to work with their skills, we want to develop a safety plan, and we really, really do work to get people stabilized and safe at home. So please don't be surprised if someone is admitted to inpatient and we're like, hey, we didn't know that was going to happen. What can we do to get them stabilized? What can we do to get them out of outpatient or out of inpatient? Because in DBT, we're saying like, hey, we want to get you using skills in your life, and one of those strategies is reaching out to us as well to help you stay safe and help you to be able to use your skills. So phone coaching is offered right now up to 9 p.m. every day, any day of the week. Both Danielle and I both have a Bellin provided cell phone that is specifically for DBT skills coaching. And so any day of the week up to 9 p.m. they can call or text, and they do get provided that information when they start DBT. Consultation team is the 4th mode. So individual therapy, group, phone coaching, and consultation team. Like I mentioned, Danielle and I are the 2 people in the DBT team at Bellin. And we also consult with a larger consultation team of other DBT providers around the US. This is to help make sure that we are taking care of ourselves, that we are using our DBT skills, and to get help with any problematic or difficult cases. Anybody have questions before we go into just kind of like the assumptions about DBT? Okay, so I just want to make sure I answer them if you have them. I'm trying to figure out how many slides I have. Okay, so in DBT.
Eric has a question.
Oh, yeah.
I'm just wondering, DBT sounds relatively new, is that right?
Like the 70s, yeah.
Oh, that's so as far as insurance, that's recognized.
Mm-hmm.
So that's always what
Yeah,
patients ask about.
Yes, so Danielle's an LCSW. I'm an LPC. I would say that the only issue that we've come across, and this is very rare, but once in a while someone has insurance that will not cover group. I would say that is pretty rare, but it has happened. So maybe I can think of like 2 people, even in the last 6 years, that were not eligible. If the patient is a Medicare patient, they do have to see Danielle because she is that LCSW, but she runs our Thursday group, so that does give them a group option. Whereas prior to Danielle joining the team, we had 2 LPCs, so we couldn't offer services to Medicare. If they do have an EDS backup, I can also bill for them. So if they have Medicare with a Title 19 backup, they can be in any of our groups and participate in any programming. And I'm licensed in Michigan, and Danielle will be too when she comes back.
And the group, that's like an intrinsic part of this, right?
Yes, you have to agree to do both. So it is individual and group. The group part is non-negotiable. That's the part where people are like, but I'd rather not. And that part's not really an option because that's the fastest way I can get people skills. Also, I would say people often don't want to do it because of social anxiety. So from a DBT stance, we're like, but this is going to help you work on using skills with your social anxiety, so like, let's do it. Yeah, yeah, for sure. Other questions about the program or anything that I've said so far? Okay. So DBT assumptions, so these are just some assumptions that we take as far as like DBT providers, because sometimes people are saying like, okay, but why? Like this is a really hard population, so you know, like what about this? What about that? So in DBT, we take the stance and we ask people too in our program to try to get behind these assumptions about each other, about themselves, about situations. So these are things that we really believe to be central about the patients that are coming into DBT and just about each other. So clients, patients are doing the best they can. They want to improve. New behavior has to be learned and practiced in all relevant contexts. So we really emphasize the intentional and purposeful practice of the stuff they're learning. There are people who can get through the program and can put all of the right answers down on their handouts because they can just think of a time where maybe they've used a skill, and they'll get by and they'll learn some stuff and DBT can still benefit them. But the people that are gonna get the most out of it are the ones that are purposefully and intentionally using these skills and strategies as often as they can. And we say like 15, 20 minutes a day. Like give me 15 or 20 minutes a day of just like looking through your materials, practicing them, trying them, reviewing the stuff. We have a ton of acronyms in DBT, but there are also like a ton of online resources that people can use to help commit this to memory. Clients cannot fail in DBT, so we believe that treatment can fail, but patients cannot. People may not have caused all their own problems, and they have to solve them anyway. We need to do better, try harder, and be more motivated to change. And also, the lives of suicidal borderline individuals are unbearable as they are currently being lived. So in DBT, you will hear about, like if you are talking about like goals in DBT, or you're reading any DBT books, or even Marsha's memoir, we're talking about building a life that feels worth living. Many people coming into our program are actively feeling suicidal and or engaging in self-harm. And even in our second visit, when it's like, hey, you want to do this, right? Like we are saying, what do we need to be doing to make life feel worth living? So assumptions about therapy. So sometimes people don't like being in DBT because it's really hard. Like we are asking people to face situations that create discomfort. We are asking people to tolerate and experience emotions. Like who wants to do that if they don't feel good? We are asking people to change behaviors that maybe have helped them get to this point in their life but are no longer functional or helpful. So the most caring thing a therapist can do is help clients change in ways that bring them closer to their own ultimate goals. That clarity, precision, and compassion are of the utmost importance in the conduct of DBT. That this relationship really is a relationship between two equals. Like I'm the expert in the DBT realm, and this patient is the expert in their life, and we're gonna come together and equally work on this. That principles of behavior are universal. They affect therapists, not just clients. That therapists treating borderline clients need support. That therapists can fail, and that the treatment can fail even when the therapist does not. So underlying assumptions, we're saying we have to treat these things. Like if you come into DBT, this is the stuff we are for sure gonna work on. Number one, motivation. People need to be willing to do the work, and it is work. And I tell people, like, I'm not trying to talk you out of this. I just want to make sure you understand what you're saying yes to, because my goal is like not to pull the wool over your eyes or try to get you to do something that you're not ready for. And we're constantly doing commitment along the way. Increasing capabilities or skills, generalizing those skills, and working on things in the environment. You probably know this more than I could ever say it, but often these environments are also so problematic. Like it is not just the person coming in for treatment, but they might need to work on changing like terms or situations in their environment, and therapists need to maintain their skills of motivation. I mentioned this a little bit before, but the primary treatment targets in individual therapy are to decrease any life-threatening behaviors, decrease any therapy interfering behaviors, and decrease quality of life interfering behaviors. And then we are also working on increasing skills. So increasing skills in those modules: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. For skills, Our goal is to reduce any behavior that's likely to destroy therapy. I will say that going online has helped reduce some of those problems. So overall, I would say online, our groups are operating really effectively. We're actually having less problem behaviors amongst group members in the online arena. Although I also understand, of course, the problems that go along with being online for 2 hours. It's hard to stay focused. It can be hard to like stay in that present moment. But we are also working on increasing those skills and then decreasing any behaviors that might interfere with therapy. And then lastly, for coaching, like I mentioned, like coaching is available. We ask and encourage people to use coaching. I want to get people skilled up. I want to help them in the moment if it feels like their skills are not working. I want to help them figure out how to get these skills to work. I want to help people continue living their lives with their freedoms and their rights and their safeties. So we are working on increasing the ability to use their skills, generalize their skills, and be safe. And then, like I said, our DBT program, so Danielle and I are the 2 therapists in our DBT program. We are hoping to be able to add new people soon. We have, like I said, 3 adult groups, 1 teenage group, and DBT for kids. That's a ton of stuff for a program with just 2 therapists. And we do accept referrals from any organization. So unlike just kind of traditional therapy in Bellin, we are able to receive referrals from anyone. They do not need to be an existing Bellin patient in order to participate in the DBT program. There is a wait list for adults, for teens, and for kids. Is it really good on time? Does anybody have other questions? I realize that is like a ton of info. It is also kind of like a general description of DBT. Doesn't necessarily go into huge detail, because we can talk about this for hours and hours and hours.
What about research, effectiveness studies and things like that?
Like, is there?
Yeah.
Yeah, so I would say DBT is actually one of the most heavily researched forms of therapy. There is randomized control trial after randomized control trial, even just around the world, showing that DBT is effective. So DBT was initially designed for that borderline personality disorder criteria, and then has been expanded and incorporating, people with anxiety, people with depression, people with bipolar disorder, kids, teens, families. There's DBT-S for DBT for substance use disorder, and just research after research. If you're looking for some really good from the source research, Melanie Harned has been one of the top DBT researchers through Behavioral Tech. So Behavioral Tech is Marsha Linehan's organization. She's now retired, but that's the organization that she created to help train people in DBT. They keep track of ongoing research studies on there. It is amazing. You could spend hours and hours reading about it, but there is so much stuff. Also, every year, there's a national conference, international really, it's called Is It DBT? And there's a review of that research every year at that conference. It's always the Thursday before Thanksgiving, so that's a pretty cool one. I've seen Marsha speak there. So if you're interested, there's a ton of stuff out there, and just new research coming out all the time. So when COVID hit, they're like, okay, can we do DBT effective virtually? People were kind of scrambling to see what we could do, and they're like, let's research this. Let's figure out if this is gonna work. So I would say there's a heavy component of the stuff we're teaching is evidence-based, it's empirically shown to be effective, and we're talking to our patients of here's why this is gonna work. Here is where the information is coming from. This is where the evidence is that supports this. Yeah. Other questions? Everybody really excited and they want to go learn more about DBT.
And Bridget said too, she sent Ariel the frequently asked questions and just some information. So when we send out the recording, we'll attach those too.
Yeah.
Then if anyone has additional questions, we can always ask it after too.
Absolutely. I mean, really, I would say reach out to us anytime. Daniel will be back beginning the 26th. I would say either one of us can answer questions. If a patient is wondering where they are on the wait list, they can just call the office. Our front desk kind of handles that wait list, specifically Melissa, she's our scheduler. If they're saying like, I returned the paperwork, for some reason I'm not getting a call, we can double check, we can make sure it's marked correctly. You know, when you're adding that many people, of course, a clerical error could happen. So if they're ever worried about it, just double check. Staff can ask and double check. Even if someone's been added over and over, because that happens too, we will always send them out the information. So if you're saying like, why isn't this person getting called? We do keep record of every referral, and we can absolutely give you more information too as to what might be happening that they're not joining the program.
Awesome.
Thanks for having me.
Well, thank you very much. We appreciate it. We did really good on time. Thank you. See you later. All right, Net Promoter Score. Is Amanda here? Okay, I was like, she's somewhere. There you go. You got this.
So, this basically just talks about the
Come up here.
the surveys that they send out to patients after they've been here. The lower scores basically just indicate that we didn't receive a whole bunch of response back. So they'll be doing something on the ABS to remind patients to fill those out, then we can get those higher scores.
Perfect. Yeah. I think you have one later too, don't you? Oh, good. All right. Average daily census. So just a little update on this. We like to share it periodically. So the darkest blue line is 2023. And then the in-between blue line is 2022. So you'll see in the beginning of the year, we were trending pretty much on track with 2022. But then so far for the month of June, we're actually 5 patients higher per day than we were in 2022. So we know that April, May, we had a lot of staffing constraints. So Ariel had the number for diversions, but we diverted quite a few patients due to staffing to make sure we weren't going way above ratios and trying to be as mindful of that as possible. So that's May, we probably could have been much higher, but we weren't, which is okay. But now for June, we're doing really well. So obviously we're not through June yet, and June and July, we know summers are slower months, so it could go down, but that's where we're at so far. Yes.
So as far as our staffing update, we have 8 new RNs starting, which is going to be really helpful, obviously, as everybody knows, with our staffing crunches. We are still short on support staff, but we're going to keep additional RNs on as needed just to cover some of those holes. And hopefully we'll get more support staff as it comes. Dr. Wanamaker is starting on the 14th. She's going to be Dr. Passoff's second half, her partner. So she'll be doing the 7 days on with her. Dr. Passoff will switch weekends, and then that's all updated on the on-call schedule that is posted on the units. Travel RNs, we're actually decreasing the need from them from 8 to 3 to 4 now through the summer. We have 2 still in the intake department. And then we're going to continue to reassess for our needs for the fall. So welcome to all the new staff that have joined us. We're glad that you're all a part of the team. Here is a list of all of the staff that have joined us. Obviously, I'm not going to go through every single name, but I'll give you guys some minutes or some moments to kind of look at that list and welcome everybody that has come and joined our team.
And you'll see too, like, there's a fair mix of child, adolescent, adult. Colette has been cross-training in intake, and she has actually decided to join our intake team. Along with that, Maddie Winchell will be transitioning to intake, so I feel like it's intake, obviously there's not as many, but we have way less positions in that department. But otherwise, overall, it looks like a pretty fair mix. And then something to call out too, obviously Dr. Tony is virtual, and then now with Dr. Johnson transitioning to more virtual, we did hire Becca as a service associate, but then we hired another service associate, Ryan. He didn't start yet, I don't believe. Just because we know that there's going to be more needs for the virtual coverage, and instead of pulling from our limited pool of core staff that we already have, we actually decided to hire 2 service associates for that. So, Flex unit updates. So you guys know Flex has been closed for the last, it'll be 2 weeks in total to do the negative pressure rooms. So they are hoping that Flex will be opened back up by tomorrow. They're doing all the last minute touches. They're going to try to put the bedrooms back together. Not official yet, but we'll share communication when it is back open. But just a little bit of education on the update with negative pressure rooms. So you'll see in the main nurses station of Flex, right above the computer where that red circle is, they now installed a little light switch basically. And the light switch is actually labeled negative pressure rooms. So clear representation of what that is. So it will be off, but if we ever need to turn that on, you literally flip the switch. When it's not on, these little meters are above the bedrooms. So when it's not on, it's red. When it's on and effectively working and good to go, it'll be green. So light switch off, should be red. Light switch is on, you need the negative air pressure, it would be green. So that is the basic of part of it. The only education we're providing today is just on that, because now infection prevention needs to look at what we have, determine protocols, what types of patients can, should go in there, all of that. So that will be next steps. That'll be sent out once it's developed. It's not yet, but we can at least reopen Flex because this construction will be done. So literally a light switch.
Jeff said too that he's planning on getting a little instruction manual and putting it above the switch there, and then also just to know that there's a 30-second delay after you shut the door, after you flip the switch on for the negative air pressure to kind of reflect. So he said sometimes it seems like you're waiting for 30 hours, but it's just that 30-second delay, just so you know.
Social determinants of health.
So this is something that the other health systems in the outpatient world have kind of used for a while. I know the therapists have changed their psychosocials and the AODs have changed a bit to include these categories a little bit more in depth. And then you can see those, there's a little diagram on the top in a couple different places in Epic. The easiest I think is on the left-hand side. You can just kind of hover over and you can see that information. We'll be kind of addressing those more in depth going forward. I don't know if that was addressed with staff or not yet, but I know tobacco use is going to be an easy one to address because we kind of already do that, especially with the adult patients. And then obviously depression, but those will be added also to the after visit summary, just kind of saying that we address those and here's, what we talked about. Things we won't address is like housing, sort of stuff that we don't really do here.
Thank you.
Alright, so fire drills, we do them quarterly. They're important because obviously if a fire were to occur, we need to know how to respond and react. So repetition is key, which is why we complete them quarterly. We do meet after as a team to discuss like what went well, what didn't go well, and improvements we can make and take away from it. One thing that we do want to reiterate is that if you're clocked in, you're expected to participate in it. So I know sometimes they have minute shift change, which is definitely inconvenient, but a fire can happen at any time. So we just ask that everybody who is clocked in to participate.
All right, Packers VIP workflow. So a few of us had the opportunity to meet with Dr. Carr, and he works for the Packers, and we were able to talk through the workflow if and when a Packer player were to need inpatient psychiatric treatment. This was actually created a while back, and then we were able to meet a couple weeks ago just to kind of reiterate, talk through, and then we did make a little tweak to the protocol. So just wanted to share, this is saved on the intake shared drive under the VIP workflows. We have other VIP workflows. We, if it's a Brown County Sheriff's Department staff, or like a firefighter, or like some of the different EMS people, we do want to respect that, and we have different workflows just to make sure that we're kind of protecting their privacy. So if a Packer player were to need to come to BPC Inpatient, obviously they might be recognized by some of our other patients, or you know, everything like that. So we just want to be respectful of that, and which is kind of where this workflow came from. So I'll just kind of hit the high level things, and then like I said, the VIP workflow is on the shared drive in the intake folder. A lot of this is intake driven, but still wanted you guys to be aware of it. So if a Packer player were to potentially need inpatient admission, the leader or admin on call should be notified. And then the Packer representative, whether it's Dr. Carr or somebody within that organization, they themselves and the player would then connect with our intake department, just like we kind of do with any patient, gather information, and then determine if medical clearance is needed. If medical clearance is needed, the ED has their own workflow for Packer players, so that would not be in our realm, but ultimately we would work with the ED to make sure their privacy is protected. Then once they come to BPC, we still have to assess them, just like our normal workflow. The only difference is they might be brought into the building a different way. So if it's the middle of the night and there's nobody in the lobby, they can walk right in just like our other patients do. But if it's maybe middle of the day and we have a full lobby of visitors or potential patients, outpatient patients, we might have them enter through the employee entrance and go into a group room, or if flex is available. Previously we utilized the flex unit. So just those little things to be mindful of, but that is very much so driven by the Packers. So maybe they don't feel it's necessary, and that's okay. We won't force them to do that, but at least know that we should at least offer that option if they're well known or feel like there could kind of be a conflict there. Workflow for admission is normal. If they're willing to be voluntary, we do that route. If they're not willing and we feel like they need to be inpatient, crisis can get involved. So all of that is the same, no matter the person. The big thing then, the change that we made when we met most recently is upon admission, when obtaining releases, the Bellin release is needed for specific individuals within the Packers organization, and the protocol that we made actually has those names. So it's Dr. Carr, Brian Engel, Gray, and Dr. Patrick something. So all of that will be listed on, Dr. McKenzie, and then James Evans. So we want all of them on there. If there's any police involvement, Doug Collins. So we just wanted to make sure that's very clearly spelled out. We learned when we met with Dr. Carr that part of his workflow already is when he is meeting with anybody within the Packers organization, they already sign a release to us. Obviously, it's not the most frequent that we get a Packer player, but at least we're then covered. So if something were to happen, they have permission to talk to us, but reversely, we would still need that permission to talk to them. So we still have to get our Bellin release filled out. Let's see, and then intake staff should notify the on-call psychiatrist for an assessment. So that is one thing, we want them to be assessed really as soon as possible. So just making sure that the provider, the psychiatrist is aware, and this was presented at the inpatient provider meeting, so they are aware of this workflow as well. And then just, we ask that you close the loop with whoever was contacted in the very beginning. Just make sure you close the loop with them at the end. So, like I said, this is mostly intake directed, but still important to just share with everybody that this exists. And then, like I said, we have other ones for police departments and individuals of that nature. Any questions at all? Okay. So then we have Eric Nelson here. So he wanted to do a little chat about chaplaincy. So we'll turn it over to him.
Thank you.
Yeah.
So, thank you for being here. Start with that. Is this a monthly meeting or
Quarterly.
Quarterly meeting?
Yep.
Okay, great. So again, my name is Eric Nelson. I'm the lead chaplain here in the healthcare system. There's 6 of us total. There's 4 of us who are staff chaplains. And we're mostly at the hospital, but we also go to some other sites. So we cover Oconto, we're going to start covering Marinette, and then we come here as well, and the Cancer Center. So we're pretty spread out. There was a period of time when we weren't covering BPC very much. I'm not sure what happened. COVID was one of the things. But now we've been covering that again. So I just thought it'd be useful to tell you a little bit about what we do and what we can bring to BPC and what happens here, which is really important. So why does this matter? Easiest way to say it is we're body, mind, and spirit. We're all three. And I'll talk about the spirit part with that, what that means. You know about the importance of emotions, of course, and that involves the body and the mind. Body we all know about, right? If the body breaks down, it's a big problem. So chaplains work a lot with people who are having physical health problems. But the spirit and the emotions can break down too. And we have a role in helping to treat that. So what do chaplains do? First, I want to say about what chaplains don't do. The most common thing that people say, well, misperceive, is that we're pastors. One of the most common questions is, well, what church are you from? And they don't realize that I work for Ballin Health. And so what's the difference between chaplains and pastors? Well, pastors, they lead congregations, they have some sort of tradition, whether it's Christianity or Islam or whatever it might be, Buddhist, and they teach that. We don't teach traditions. So we don't come in and say, well, here's what you need to believe. We never do that. We start with what patients believe and where they're at. And we provide emotional and spiritual support. And we listen more than we talk. Pastors, priests tend to talk a lot, they're preaching, they're teaching, they're running things. Chaplains, as chaplains, we do a lot of listening. Sometimes that's listening in silence. I know when people are, for example, very depressed, they don't always want to talk a lot. So those sorts of meetings might be a little quieter. We're there listening to whatever they want to give us. Okay, so let's talk about spirituality a little bit because I think it's important to define that. So spirituality is going into the deeper mysteries of life rather than the everyday. Okay, every day we do certain things, right? We get up, we brush our teeth, we have something to eat, go to work, have lunch, home, eat some more, maybe do an activity, then we go to bed. What do we do the next day? We do the same thing usually, right? Except on the weekends. And we do something different, hopefully. And that's fine, that's everyday life. That is how we're created. Spirituality is about what is the bigger picture. So 4 aspects of that. One is transcendence, or what takes you out of yourself. What is that thing? For a lot of people that is God, but certainly not for everyone. Yesterday I was talking to a group, and 3 of the 4 people said it's the night sky. That's what takes them out of themselves. That's what gives them transcendence. In fact, I was working with the adolescents, and they said that, so I thought that was pretty cool. But it's just something greater than ourselves, like a higher power of some kind, but it doesn't have to be supernatural. Second aspect is connecting to other people. You all know that if people are disconnected and lonely, it's really bad for mental health, right? And so part of spirituality is connecting people. Traditionally, if you're a member of a church, right, you get together, they sing, they pray, they talk to one another, those connections are formed. Same thing happens in like a Buddhist temple or a meditation space. Religious do a lot of that, but can happen in spirituality too. When I was talking to the adolescents, 2 of them brought up dancing as a way they felt connected to other people. But that was kind of cool. So making connections so people aren't as lonely. Meaning and purpose is a big one too. What am I supposed to do in life? Why am I here? Maybe you ask that question, right? I do sometimes even. As a chaplain, what is my role here? That's a question of meaning and purpose. And if we don't have purpose and meaning, then life's sort of like, well, what is the point, right? A lot of people ask those questions sometimes. The last part of spirituality is something I call virtue, which is being good. And this one is, it can be like good in a, I don't want to say a negative way. What do I mean by this? Virtue is like habits of goodness. And why would this be important? Well, if we treat other people poorly and treat ourselves poorly, how's our mental health going to be? Probably not that great, right? So it's a thing of well-being and building social connections. If we don't have that, we don't have a lot of other things. So I talk about that as well. One huge thing that comes up in this department is forgiveness. So when I work with groups, I would say at least half the time someone will bring up the question, well, what about forgiveness? Do I have to forgive this person who did X, Y, and Z to me? And we'll talk about that. Sometimes my entire group is focused on forgiveness. So that's a kind of virtue, right? Forgiving. It's good. But it's hard when you forgive. Is forgiving the same as reconciling? The answer is no. We could just talk about that. So virtue, that's one of the virtues that comes up a lot in my groups. And spirituality is a coping skill. It helps us address suffering, psychological suffering, substance abuse, suicidal ideation. A lot of our consults are people who are struggling with that. And we bring the tools that we have. Okay. So, one thing that I've learned is that there's lots of conversation to be had. When I started this, I felt strongly chaplains needed to be at BPC. And so I raised my hand and said, I'm going to develop this area. But I was like, I don't know what this is going to be like. Right? But it's been incredibly powerful. The richness of the topics and talking about meaning and purpose and why am I here and how do I find inner strength? That's the kind of stuff we talk to, as well as the emotional support. So if you see those themes, people talking about those things of, what's my purpose? How do I find strength? How do I be good? How do I connect with people? What's my purpose? Just think, maybe I would want to talk to a chaplain. And then remember what a chaplain is. Just like a one-liner. They listen and provide support. You might get some people who want to talk to the chaplain. We would love it because we love doing this. And we're seeing a little more consults for that, which we're really excited about. 3 of the 4 chaplains take these calls. We have plenty of people to respond to consults. And we regard any consults here on the same level as the hospital. So they pop up on the same screen and they're assigned to somebody and then there is a response. So if you have someone that want to talk to a chaplain, the best way is to place a spiritual support consult. I don't know how many of you know how to do that, but if you don't know, I'm sure a more experienced nurse, I don't know how many of you are new or established. Anyways, ask someone. And they'll show you how to place that consult. If it's something urgent though, please call us, pastoral care office, or have us paged. Like someone's just really upset, they're worked up, and you think, a chaplain could really help, page us, and we'll come right away. Usually what we'll do is we'll call back and say, when's a good time for us to come? That's usually the question we'll ask, because we know you have groups and different things, and it can make it hard for people. But we'll come anytime, including off hours, because we have call chaplains, so we can cover that as well. Okay. So I'd like to take any questions you have about chaplains. Yes.
Are you there for our employees?
Yeah, thank you for asking that. Yes, the answer is yes. We do quite a bit of staff support, and so a lot of it is informal. We're back in the nurse's station, and we're like, "What's going on?" I know something is what happened. Maybe there was an incident that needed to be discussed. We do debriefs if something happens, a case that's really hard for staff here, and we can help in that way. We also meet individually with staff if that's needed. We're happy to do whatever's needed. Yeah, we do a lot of that.
Would
And
you
we do
want
that.
Zach to call if that was the case,
Yeah.
or what's the preferred?
So the best way on that is to call the office. So that's 3482. And we monitor that phone. We usually pick up voicemails at least 3 times a day. And then we call you back and discuss what the nature of the situation is, and then respond that way. And if it's a crisis situation, we'll get someone out right away. Or the next day, like if there's a critical incident, what we call them, then we try to respond to that within 24 hours. far as doing the debrief and that kind of thing. Okay, did that answer your question? Okay, other questions? Okay, thanks for giving me the time.
Yes, thanks so much.
Yep.
All right, so Marina mentioned at our last quarterly meeting that we were kind of going away with the mock drills. We weren't finding that they were the most helpful. It was hard to take. Katie Devery was usually our mock patient, and it was kind of hard to separate that and actually go through what a real code would be like. So to transition away from mock codes, we decided to do a move of the meeting. So last meeting was the children's holds, and then this one is just the high level hold. So we'll just demonstrate it quick. Marina's not here, so we will be your demonstrators. Oh yeah, Alex. Sure. Okay. Go on the camera, Stace, you're fine. All right, so if you have a patient, it's the hand on the inside of the wrist, and it's tucked up under the armpit, and then you're covering their hands just so they can't scratch. Part of this is if you're walking, you can utilize your hip. So if we're trying to walk, we can kind of direct. This might be used as like an escort type of hold. And then part of this too is a reversal. So if you're walking and you feel like you need to do a reversal to get the patient out of a certain area, you take your outside hand, you swoop under the armpit, and then you turn, and then you would, we're running out of room, you would turn and then walk the patient back. So that is the CPI move of the meeting. Let me see if Marina had any notes that I did not cover. A caution to be aware of. So if a patient were to drop their body to the ground when you're doing a hold, help them get to the ground safely. You obviously want to keep yourself safe as well. Help them get to the ground safely and then reassess. So is it appropriate to continue the hold if they're still trying to self-harm or harm somebody else with their hands? Maybe it's appropriate to disengage. Maybe they want to be on the ground and they're kind of starting to calm down. Or if absolutely necessary, is a floor hold needed, again, based on the severity of what's going on. So that is one of kind of the more basic overviews of the high level hold. There we go. Press 80 survey. So you all should have received an email. I don't even remember the time frame of it, but it recently closed. And it was regarding feedback. So overall, the survey is closed. Overall, Bellin completion rates was at 82%. For BPC, we had a completion rate of 64%. So although we were under the overall, 64% is okay. We obviously would be hopeful to have a bit more. What this survey is, so I'm trying to remember what this used to be called. Pulse survey? Okay, so this used to be called the Pulse survey. They got rid of that, combined a few different surveys. Instead of sending out 3 in a year, they kind of combined it into one. And it's basically the employee feedback survey. And what happens is now that it's closed, they total up the scores on how people responded. We get copies of the overall scores, and then we also get copies of the comments. So it's anonymous, so there's not a name attached to the scores or the comments, but we get overall scores by question, and then literally just a list of comments. From there, we review it, and then we look for themes. So we review it internally, but there's also like the senior leadership for Bellin. They actually review it too. So it's very transparent within the system. And then look to, based on those themes, what can we do? So a common comment that comes through, and it probably will this year too, we didn't get them yet, is about staffing. So, are there components of staffing that we can control? Yes, but quite limited because of the shortages. But if we look for themes of things that we can control. So then from there, we might make changes to workflows, we might do a trial of something, So that's kind of where it all stems from. And then one of the things I just wanted to ask, so when we get the results, we will identify themes. I'm sure we'll share them. I think we did last year. So once we get those, we will share kind of general themes with everybody, so everyone knows where we were at with that. But a question too is, we were at that 64%. This will again happen next year. So if you guys feel that there's anything that could have been done differently to improve the response rate, if you don't mind chatting with one of us, send us an email. I'm not gonna pick out anybody in the crowd unless you want to, but is there anything that we could have done differently to help increase the response rate? I feel like it was kind of weird timing with the team meeting. So last team meeting, I don't think we reviewed it, and then it kind of came out before this one. So I feel like that might be an area of improvement. We probably should have done some education beforehand. But if there's anything else that you think of that could have been useful, just let us know. And then, like I said, it'll be out again next year. So do your best to reply if you are able. All right, charge nurse update.
Alright, so now that we have 8 new RNs starting, or 8 total, 5 are not new, they're SNTs. But we're hoping to actually have our charge nurses function within the charge nurse role. I know as a leadership team, that was one of our goals for this year, to help empower our charge nurses and to help staff recognize what a charge nurse is and kind of what they should be involved with. So ideally, our charge nurses, we want to take 3 or less patients. If they are able to, they should be able to function fully as a charge nurse. If they do have to take more, our charge nurses are great at still functioning within that role. So one thing we want is that intake should be updating the charge nurse only. If you're on the unit and intake should be asking for the charge nurse. If they don't, if you answer that call, just be like, let me put you on hold for the charge nurse. Just because then they should be aware of every assessment that's coming. They should be the ones. Stacy put it great earlier by saying that they should know the pulse of the unit, so they really should be providing the bedroom numbers and everything like that. Also, charge nurses should be aware of any changes in patient status or acuity. So if you have a patient who's kind of amping up, grab the charge nurse. If you have a patient who have a critical lab value, come in, update the charge nurse. If a patient's going to the ED, update the charge nurse. Really, they should be involved in every aspect of the unit. Even if there's a difficult spouse or parent or whatever, the charge nurse should be informed of that. And the charge nurse works closely with intake, the house supervisors, as well as the team facilitators. So if there's a situation that you're struggling with, go to your charge nurse first, and then if they're unable to kind of handle the situation, they can go higher. What else is there?
One thing to call out, so some of our charge nurses are saying that there's times where they're not aware of a situation and they could have helped. So I think that just further reiterates that they are here to help. That's kind of why they're in that position. So just being mindful that, if you let them know, and like Alex just said, if they have a full patient load and they do not have the capacity to help with the challenging parent, well then they can reach out to intake. And side note, but related, I know our intake staffing hasn't been the greatest either, so I know we've fallen kind of away from our true house supervisors and them kind of overseeing, but we are looking to get back to that. So one of our more recent updates that will be coming is we are going to be reminding our intake staff of rounding on the units, making sure that you have a good pulse. I'm going to use that word again, having a good pulse of what's going on, because you are the house supervisor. And at no fault to anybody, but we've gotten away from that because of our shortage of nurses in our intake department. So a goal of ours is to empower our charge nurses and then also get back to that more house supervisor department. So if the charge nurse can't handle it, maybe intake can help. If intake can't help, the TF can help. If the TF can't help, I can help. Just making sure that we're going to the right people. But we're hearing that sometimes our charge nurses can help, they're just not aware. So now that we're really hoping to allow them to have the capacity, that's why we want to bring this forward. If they have 6, 7 patients, we know that isn't the most realistic. But and then along with that too, if you are charge nurse on the child adolescent unit, but maybe adult unit is getting 3 admissions, you can jump over there too. So don't feel like you're just restricted to your unit. We all work together, obviously. We float amongst each other. So if you have the capacity, or if our charge nurses have the capacity, we can do that too. So don't be afraid to ask. And then my last comment, and then I'll see if they have anything else to add, but we know that there are shifts where we don't have a charge nurse. Totally understand that. If that's the case, just try to go to the most senior nurse, or if you guys just designate, hey, you're our contact person today, let intake know, or the unit just decide upon that, then at least it's going through one person. We have some goals with communication. We want to bring potentially the handheld like rover phones to intake, because then if a message is sent that we have an assessment coming at 6 o'clock, it would theoretically go to the BPC adult unit, and then everyone gets the message. So just helping to kind of get rid of some of those communication gaps. But we're not there yet. We're in the very early stages of that. So a potential, not guaranteed, but we're hoping to. But ultimately, it just makes sure that things aren't falling through the cracks. And there will be times where they will, but at least we can hopefully decrease it.
And we just want everybody to make sure that respect is given to the charge nurses. They're the unit leaders. They have, the backing up leadership when they're here. And so just wanted to call that out there, just because they're charge nurses for a reason. We kind of want to just bring it back to what they're doing at the main hospital. The charge nurse knows everything about what's going on the unit. So yeah.
Along with that, charge nurses, apart from knowing everything that's going on, they're able to make decisions. So if we have too many staff, as the night's winding down, they're free to send people home. If we have staff that aren't as uncomfortable as it may be, if the charge nurse feels like they're not working within their role appropriately, or if they're really negative or being disrespectful, they are more than welcome to send them home. So yeah, if people need to come in and the charge nurse thinks like, hey, we could really use another nurse, they're able to call somebody in and make that decision. We'll completely support that.
Civiltas. So I don't even know where we're at. I deleted the link anyway. So we thought we were going to be way over on time, so we actually decided not to play the Civiltas video here in person today, but we will send out the link for it. It's interesting because we have like DBT and we had chaplaincy come, and actually the Civiltas topic is mindfulness, so it's just kind of nice how it all relates. But the key point is mindfulness is a way to manage stress and build resilience. And the present moment, the now, is the time that you can have the most impact. So again, there's a short video. There's some like questions to kind of think about and like self-reflect on. So we thought, for the purposes of time, that we wouldn't play it today, but we're actually doing really well. But it'll be sent out when the actual meeting gets sent out to staff. Code buttons. So I feel like I've been updating you guys kind of periodically with this. It's a sore spot for me and probably a lot of you. So we've been working with the Code Button company. When we initially implemented our Code Button system, from the time you hit your button to the time that it went overhead was 9 seconds. And at the time, 9 seconds is realistically, by the time the buttons hit, it locates where you are and goes overhead. That sounds pretty realistic. However, we've noticed as from the time we implemented it, as time goes on, the delay is becoming longer. The most recent testing that Alex and I did, it was averaging like 25, 26 seconds, and that is absolutely too long. So I have been part of some meetings with IT has been aware, facilities and security, and then the actual Code Button company, looking at where did this delay come from, how do we fix it. If we can't fix it, we're going to look at a different code system because this is just ultimately not meeting our needs. So we're working on it. We have given them, I think meetings are like once a week or every other week to really like keep the ball rolling here. And if we don't have a resolution relatively quickly, we'll probably start to look at other options. So in the meantime, because we know that this isn't gonna be fixed tomorrow. I just want everyone to be aware of the delay. I feel like that's what we can do right now, is just be aware of the delay. If there's a high acuity patient and you're going in there, bring another staff member. I know we proactively do this all the time, but have security kind of hanging out if you know a patient's gonna maybe not have the best family therapy, whatever that looks like. But then also know that the mounted push for help buttons, those are still 9 seconds. So if you hit your wireless pendant, it's like 25, 26 seconds. The ones that are mounted on the wall, when we did our testing, they were still very much so 9 seconds. So if there is an urgent situation, we usually identify a code runner, maybe that person where we designate somebody to go hit the nearest push for help button. It's not a great workflow, but ultimately it's the best we can do at this point. But just know that it's very actively being worked on. So the biggest thing we can do is just be aware, but then again, knowing that the push for help buttons is a true 9 second, and it's the white ones that have the big red button on them. They're in the offices, the group rooms, kind of periodically, sporadically placed. And then the last thing to note, so when meeting with the company, they said we should educate our staff on how to hit the code button. I gave some feedback on that, but ultimately said I would do my due diligence and share. So when you hit the button, it's literally, you just have to hit it and let go. They said that there might be issues with staff like hitting their button multiple times, and that ultimately overwhelms the system. I said in a high acuity situation, I don't think staff are gonna like be thinking of how to hit their code button, but I said I would do my due diligence and share that. So I know our old buttons, you used to have to push and hold. These ones you do not. You like literally push it and release it, and then it'll take its course and then alert overhead. So you've all been educated on how to hit your code button, but that's not necessarily the issue. There's a bigger issue and we're working on it. Infection prevention. So Christine worked nights last night and she works nights tonight. So I told her I would just do my best and cover this for her. So she made a couple of resources that are available on the units. So just wanted to share that. The first one is the different types of infections, the duration, and then the different precautions that go along with those infections. So that is this binder. There is one on both units and an intake. The one on child adolescent is by the Adolescent Work to Do board. It's like the red lettering on the outside. Adult unit, it's where all the binders are. So if you're walking towards PI on the left-hand side, and then in intake, it is by the shred bin. In here, it goes through pretty much every infection you could ever think of and talks about the precautions, how long you have to be on precautions, what's required to come off of it, etc. So it's just a really good resource. All of these things can be found on Julius too, but it's nice to, instead of having to search for it, it's just nice to have a resource binder. So that's what this one looks like. The isolation cleaning and PPE cart guide can be found on the little like infection prevention areas on each unit. So that is this one, and it just talks about the different cleaning. So what is required when there's, the different precautions. So if it's airborne, if it's this, if it's that, if someone has lice, what do you clean? What do you do? So it's kind of a 2-page resource there. And then she wanted to just share, so staff might not be aware of this, but Christine is our infection prevention liaison for BPC. And then overall Bellin, we have a couple, I don't know their true title, but they're like the infection prevention staff. So our person is Nikki. So Christine and Nikki round, they used to do it monthly, but we were doing really well. So we were actually able to decrease it. So now it's quarterly. And what it is they go through pretty much everything. I'll leave this out if any of you want to look at it after, but they go through everything and identify what opportunities we have. So for example, they went through and looked at all of the vents and made sure that our vents are free of dust. Something that I wouldn't necessarily think of. Hand sanitizer dispensers, where are they at? The storage rooms, are they clean? One of the findings was that the adult unit fridge had something spilled on it, which, great, so then we cleaned it. So again, it's like this whole document, they go through, they take pictures, the things that can immediately be fixed, they fix. If there's things that require a more long-term plan, they establish those. So she just wanted to share that the follow-up items, some of them have been completed, some of them are in progress, you might see communication about them, etc. So I have that if anybody's interested in learning more about that process.
Okay, so we've continued doing the staff pickup drawing. We've been doing this, I think, since October. So pretty much staff we pick up, every shift or half shift you picked up, you get entered for a drawing. In May alone, there were 151 pickups, which is, we've seen it like continue to uptick each month. I feel like with the incentives, it's definitely increased quite a bit. So in March, Lexi won a gift card, in April, Andrea won, and then in May, Alex won. So thank you everybody who's been picking up.
All right, so then this is the very last part of our meeting, so we're gonna turn it over to Elizabeth. She is one of the health coaches, so she will just kind of give some information and then we'll go from there.
Hi, thanks. I really appreciate being invited to this quarterly meeting. And if you guys need to stand up, stretch, take a deep breath, and do so. The reason why we are coming out to the clinics and ancillary services, specialty clinics, is because we want to make sure that no matter how long you've been here at Bellin, that you know your benefits. I can speak for myself, being here about 27 years, I didn't even realize the benefits that we had. You know, we're all really busy, and when we first start, we get a mound load of paperwork, and we are only trying to absorb the job and what we need to do. So we are here to explain any benefits that you might not even know about. So first I want to just let everybody know it wasn't really kind of marketed to individuals yet at Bellin. Is a new program called Lifestyle Medicine, and if you take the Bellin insurance, it is free to you. It's a huge program trying to create lifestyle changes, specifically working in 6 pillars of health. So substance abuse, stress, sleep, nutrition, dietary, physical health, and also relationships. And a lot of people don't know that this is a free service for you, so we wanted to let you know about that. Then we also, in Epic, there's like a green button. If you look up anybody in your first screen, when you're on a patient, there's a green, I forgot what you call it, a something banner. If you right click on that, there's this sheet, which I have in the back for you, of all the free stuff that you can access. A lot of people don't know that there's a free nutritional consult that they can sit down with a nutrition person, and if they want to get information on dietary changes that they might want to make, help with dietary needs to help bring down their blood pressure, cholesterol, that's all free for us. As well as the fitness memberships, which I'm sure you're probably aware of, but a lot of that we get reimbursed based on the quantity of time that we actually access the gym. So I see that you guys have gym equipment here. Is that for your staff?
It can be, yeah. I don't know if we don't have that many that use it, but it can be used by staff.
So that's great, because a lot of clinics would love to have that ability so they don't have to travel anywhere and can get in some physical activity. The free walk-in injury assessment at Titletown is also available. So if you have any aches, pain in any type of your body, they can help you. and you can walk in and that is a free visit for you too, as well as the Bellin First. If you're on our insurance program, there's lots of free benefits for that too. Also, we're here as an adjunctive therapy or help with HR, so helping you navigate where to find things within Bellin, because there's so much information and we get fearful of maybe asking somebody. Definitely ask a coworker, one of your leadership persons, but we're here too. On that table in the back is a little flyer of the 3 health coaches that we have here at Bellin. Myself and Jackie are the ones, health coaches that work in this area, and Marla, she's part-time, she works up in Upper Michigan, Oconto kind of and upwards. And that's what I wanted to explain to you here today too. What is health coaching? What are you guys? Most of the time, I would say a good 90% of the people just attach us to the insurance plan. You know, we're one of the activities that you can do to get your 100 points if you take the Bellin insurance plan. There's health coaches also with health partners. We want to let you know that our program is totally different than theirs. Not that theirs is any less or better, or ours less or better either, but it's different. And listening to your meeting today, I think it really fits in perfectly that I'm here today because along with the civil task message, that is what we do. We are, okay, so if you don't have the Bellin insurance, we are able to help you too. So health coaching really dives into what you guys have been speaking about today, that mindfulness and awareness, being in the present moment. So helping you develop those skills so you can make any type of change that you want within your personal well-being. That's in the areas, you know, we like to think a lot that when somebody speaks of health, our kind of first go-to is physical health, right? I notice you, and we make a quick judgment on your health. But we want to let you know we work in all areas of health. So when I was at Bellin, I've been here about 27, 28 years. If I even realized that we had health coaches, what I thought they did, probably because I'm an RN, that they just helped you with your blood pressure, maybe diabetes, maybe your weight, maybe with your cholesterol. And at that point, I'm like, yeah, I don't need that. I don't have those issues, so I can kind of just release it. But we're way different than that. So personally, for myself, about 9 to 10 years ago, I sought my own help through a health coach outside the Bellin system. Didn't even know we had them. And I found it so beneficial that I really wanted to get into this area. So I've been a health coach for about 3.5, almost 4 years. And we work in all areas of health. So physical health, emotional health, mental health, spiritual health, financial health, occupational health, environmental health, all those areas of health, intellectual health. So if you ever feel like you want to make a change in any one of those areas, we are here to help you. And we truly believe that you can make what we call a lifestyle change. And I know that's kind of a buzzword, lifestyle, meditation, be aware. They're kind of overused terms at this point, but I know for myself, that's really what changed me. You guys all work in mental health, perfect, because really it's about changing your mind, your mindset, your mental pathways that we've developed along the way. So, for instance, those mental pathways that we've developed sometimes hinder us from making a change. And so we have got to, it's called neuroplasticity, and we can still change our brain and develop new pathways to serve us well. So if you have a pathway of, which was one of mine, I'm just not good enough, I'll never measure up, it caused me to kind of have conflict within my life in trying to please everybody so I could get that affirmation of that I was good enough. And so along with that, you know, we're true believers that, I should say just for myself, that if we have good mental health, our physical health and all the other avenues of health will align, okay, and get you the change you want. Sometimes, you know, let's say anybody would go to their physician and let's say they're a smoker. You know, they know smoking's bad for them. Their loved one wants them to stop smoking. They themselves think, well, I wish I could change, right? But if they feel pressured from somebody else to change, they might change for a while, and then they're back to square one. They start back to smoking. So we want to change that. We are trained in well coaches and in lifestyle medicine to help you make this change. So we're a true believer that you have to want to change. So if people are forcing you to create a change for yourself, it most likely won't be permanent. So we don't tell you what to do in your coaching experience. We guide and maybe brainstorm things that could help you, but ultimately it's something that you come up with a change that you want in the area of health. With that, do you guys have any questions? I do have information on the back table there for you and some free Bellin gifts if you want to take one. Please do. And you can reach out to us. The best way to get a hold of us is through email. We do have phones that we kind of we call into maybe once a day, every other day, and get that message and get back to you. Any questions? I do have a question for you guys. You know, we're here to support you, and we would like to know if those of you who've been here for a while and know some of the benefits that Bellin does provide, is there anything that you see that you know, like, wow, if we really had this benefit at Bellin, it would really help me? Any sort of, because we want to introduce, this is why we're here, to get your input on what you would like to see as a benefit that you know, hey, if I had this benefit, it would just be really awesome. I know we have discounts too throughout the surrounding areas for us if we go to their establishments, like percents off too. Anything that you'd like, sky's the limit. You want to have, you know, flexible scheduling. What would you like? Please email of those who are watching this video if you have any suggestions too. Because if we don't make our voice known to human resources, they don't really know what we want as a benefit. Anybody?
Love to bring.
All right, and you know, we really want you to know too, is that we've been under tremendous stress, especially over the last 3 years. And we need to take care of ourselves, and we need to have that self-care and that ability to be able to do the jobs that we're doing, right? Because we know nurses are short-staffed, so we don't want to lose any of you because of stress that you're experiencing. And I know your team leaders Support staff would want to know that too, if you're struggling in any area, so we can get you the help that you need. That, to me too, was always something that I felt I couldn't do. And you might experience that too, just because you are in the mental health field. I thought I would be less than if I asked for help. And really, in changing my mindset, that's a strength to ask for help. So please know that any of you can ask for help too. There's many people within the Bellin organization that use health coaching, and for the insurance, you have to do it 4 sessions. But of the percentage of people that we do health coach, and that's from senior level leadership people do health coaching, all the way through any sort of job description, people contact us. The majority, I would say, at least probably 70% continue coaching well after the 4 sessions. And because this is kind of an avenue that is being accessed throughout the country, there's now CPT codes connected to health coaches. Because if you've ever been in a doctor's office, which I assume we all have, their time is limited, right? And so they will tell you, okay, work on exercising 150 minutes a week and, decrease your stress and eat good, right? And then we leave. And lots of times they consider, because we're in the healthcare field, we know everything, right? We need help too. And so these health coaches are being attached to physicians now, and so that you can access their staff to get more help. Thank you for your time.
Thank you so much. All right, and we purposely put Elizabeth at the end too, because then after the meeting, if anyone wants to chat with her or has any further questions that you'd like to personally ask versus in front of the group, you absolutely have the opportunity to do so. So that is it for our scheduled agenda. Does anyone have any questions about anything we covered at all? Okay, so we are done a little early, so thank you guys for coming. We appreciate it. And then if there's anything, so this is quarterly now, so if there's anything you'd like to see at the next meeting that we didn't cover, just feel free to send an email or come talk with us. That's good too. There's snacks in the back, so feel free to grab, there's some pasta, and we have plates now, and so feel free to grab some of those things. And then Elizabeth said she has some things too. So, thank you.
Also,